So like,
How's everybody doing for a Wednesday?
doing okay. How are you?
Doing good, thank you. Guys, keeping up with all your classes, doing your best. Okay, we'll wait a few more minutes before we get started. So how are all your other classes going? You enjoy, most of you in Med-Surg and Peds? How are they going?
Mm, I'm just in peds.
You're just in Peds, okay. How are they
It is
going?
it is kind of hard to keep up with everybody.
I bet. Yeah. Are you enjoying them?
Yeah, they're definitely interesting.
Mm-hmm. Can you see how both of these classes help you have a better understanding of community? Don't have a lot of head nods, but you do need
Yeah, they all
pediatrics. You do need
they all
pediatrics for
intertwine.
you. Yeah, everything's intertwined. You're providing nursing care in the community to all different age groups, right? And nursing care in the community is not just community oriented nursing, looking at all the health, maintaining health and keeping your community healthy, but remember community-based nursing is working in the community with the ill or the clients. And the best I can think of to take away from peds is my old role the last 20 years as a school nurse. One of the requirements of the school nurse job is pediatric experience, right? Pediatric knowledge, right? And then med surge goes along with everything, right? So, all right, I'm going to get started since it's 1 o'clock. We're going to cover, oops, hang on. Let me We're going to cover last week since it was exam week and this week. Okay, so we're going to cover week 3 was rural and migrant health, poverty, homelessness, poverty, teen pregnancy and mental illness, and then alcohol, tobacco, and other drugs. Okay, so we're going to cover that, and then we'll jump into this week, which is government, the law and policy, faith community nursing, and then what is public health, home health, palliative and hospice. Okay. So a couple of things before we get started. Oops. All right, just checking people, still checking people in. Okay. Not everybody. Missing 2 students. Okay. Case studies, your first group project. Fantastic. I graded them early this morning. Really, really good job. Really good job. Sorry, still checking people in. How did you enjoy doing it? How did you enjoy? I didn't hear from any group that they were having any issues getting together with communication, getting the project completed. Tell me how it worked for you.
It went decent. It's a lot easier when you have like everybody's numbers and communicate like text message wise. That way it's just easier to communicate with each other.
And I tried my best to keep it within campuses so that you could work on campus if you were all together. So I did my best. The numbers didn't pan out evenly, but I did my best. So did you did you enjoy doing your case study? Did you learn something? Okay. Why do you think it's important that we do in nursing in general? Why do we do group projects? What's the benefit?
So we can learn how to work with other people, communicate.
Yep. What else? I mean, in nursing, you're always going to be working on teams, right? You're always going to be working on teams, communicating with people, whether physicians or support staff or therapists. Okay, you're always going to be part of a team. So there is a reason we do group projects. And it is to get used to working in a team. Have you done group projects in any of your other classes? No. Okay. This was your first group project. Okay. Wonderful. Well, you guys did a great job. As far as exam 1 goes, for the most part, the class as a whole did pretty well. There were some grades that were below 78. I sent out an announcement yesterday and asked that you schedule a time to meet with me. If you score below a 78, I highly encourage that because during exam reviews, we go over the concepts that you missed, as well as trying to identify what kinds of questions you missed. Select all that apply, priority questions, maybe negatively asked questions. And we try and come up with some strategies of how to attack the next exam better. Okay, so I think that's everybody. Okay, so for those of you that score below a 78, I really would highly encourage you to reach out and set up a time with me. I've only heard from 2 students so far and have scheduled both of those sessions, review sessions. Don't be afraid. Don't be afraid to review the exam. It's not It's not a negative thing. Some people think of, sometimes I call it tutoring, review the exam, we'll do some tutoring. Tutoring is not a negative thing. It's a good thing. Okay. So don't be afraid to reach out. All right. Anybody that scored above 78, you're welcome to schedule time with me as well. We'll go over the concepts that you missed. Okay. I have students that score in the 90s that want to know the 4 or 5 questions they missed. I think I need to mute somebody. That there's a lot of background noise. Let's see. Kelly, can you come on camera, please?
My camera isn't working. I can try to sign out and log back in.
Okay.
It's not wanting to let me log in.
Why don't you try that?
Okay. Thank you.
Mm-hmm. So anyway, with regards to the exam, highly encourage you to schedule time to meet with me. Okay. Give me, as I said in the announcement, give me a couple of days, couple of times that work for you. I do teach on Fridays. Anyway, just reach out. Okay. For any of you that are repeating the class or re-entry students or SAP students, please reach out to me and schedule check-ins, regular check-ins. I'm happy to meet with you. I mean, obviously the goal is to get everybody across the finish line with this class, right? So anyway, that's my 2 cents for the exam. I mean, overall, most students did well. What questions do you have? As far as you guys, I believe it's week 4, so you have a case study. Well, you have one of your HESI case studies, correct? So you don't have to send anything to me. Okay, your grade for your case study, and the grade for the case study is 1 and done. It's the first time you do it, that grade gets populated into the grade book. So you don't have to send me anything, any screenshots or anything that you've completed. I'll see that in the grade book. Okay. And as far as NCLEX, you guys have done 1 NCLEX, right? Oh, I think you've done 1 so far. I got several low scores, 40 or below. But they didn't come in till the end. And so I couldn't, remember I told you in week 1, if you turn them in early and they're low scores, I'm going to try and send it back to you and say, I've reopened it and redo it for a higher score if you'd like to. Unfortunately, most of the lower scores came in that Sunday that it was due. And so I couldn't reopen it. It was too late. So again, I'll repeat what I said in week 1. NCLEX assignments are really, really good practice. Okay, very good practice. They're good practice for content. They're good practice for rationales. If you get questions wrong, it provides you rationales, and you already know how I feel about rationales. Rationales are an excellent way to learn. Okay, so there is a reason we give you 4 NCLEX assignments. Okay, if you're scoring below a 40, okay, Kelly, thank you. I'm not sure what else to do if it's not working. So NCLEX, please, you can do NCLEX as many times as you want and submit your highest score. If you're submitting a low score, that probably means that you didn't pay a lot of attention to the questions you got wrong or the rationales that come with that. Okay. But again, I don't know how many times you've done it when you submit it. People that are sending me scores between 45 and 50. I don't know if it was your first time or if it was your 10th time. I don't know, but I can't stress enough the importance of these NCLEX assignments. Okay. They're good for learning. They're excellent content review. Okay. So that's my spiel on NCLEX. Just so you know, for those of you that are below a 78, this week we start at-risk meetings. I don't know if you've heard about those before. You should have in your previous classes, but anybody below a 78, I need to complete an at-risk report. Okay. And I tell you about these in week 4, because if you get contacted by your dean and they're asking about community. Hey, you have a low grade in community. Have you reached out to the professor? Are you scheduling tutoring, reviewing exams? That's why, because we have to, all faculty have to fill out at-risk reports for any student below a 78 that's having attendance issues, that's having homework issues, not submitting homework. And those go to your deans every single Monday and Tuesday. All right. So if you're if you know you're below 78 and you're hearing from your dean, that's because they've received an at-risk report from me. So I don't want you all to be surprised. I'm not tattling on you. It's a way that online communicates with campus. And they're actually excellent meetings. And then every other week, so for example, today we had Richmond, Norfolk, and Scranton. Okay, so we met today and then we meet 2 weeks from today. So every single campus meets every other week. Does that make sense? So this week we have 8 different campuses. Next week we have the other 8. And then they rotate all the way through week 10. Okay, so we meet in person every other week, but we send paper reports to your deans every week. Okay, so just FYI. All righty. Okay, I think that's it. Anybody have any questions? Okay, let's go and do some. Did you review? Did you prepare for week 3? Do you remember what we covered, what you were to be reading about in week 3? Anybody? Week 3, we were covering rural and migrant health. That was the first chapter we covered in chapter 24. Okay. So let's bring up some notes. Okay. These are my notes that I use. So let's just go through it. What do you guys, when you think about rural health, what do you think about? What's rural health?
Out in the country, away from the cities.
Mm-hmm.
Farmers, farmland.
Okay. What else?
Small towns.
Okay. What do we think the population, what kind of communities gather in rural communities? What kind of people? Think there are any popular ages? Typically it's below 18 and over 65. Okay. What do we think about healthcare in the rural communities? Is it like the urban communities? And how is it different?
Less technological advances in the smaller communities because of funding and stuff.
Yeah. What else?
Less specialists in the area, so less
Perfect.
access to
Yep.
to healthcare they need.
Mm-hmm.
I was gonna say not as many people, like not as many clinics in the area, so they have to drive farther to get care.
Yeah, absolutely.
And some places don't have emergency services either, so.
Mm-hmm. Yep. Transportation, big issue in the rural community. Yep. So let's read about this a little bit. Rural. What does rural mean? Maybe it means living on a farm, village, small town. Okay. There has been a population shift in the past decade from urban areas out to the rural populations or the rural communities. Okay. Vulnerability is a huge issue in the rural communities. Okay. Like we said, living in a farm or a village or a small town. Okay. the proportion of residents typically younger than 18, older than 65. We know that they have fewer years of education with far fewer college degrees. And the sad part, one of the sad parts about the rural community is more than 1/4, so 25% of rural Americans live in poverty. And nearly 40% of kids in the rural communities are impoverished. Okay, so children are most at risk. Okay, as are racial and ethnic minorities and single parent families, especially the single parent families headed by women. Okay, somebody mentioned insurance. Fewer residents have insurance. Okay, and then there's definitely more high-risk occupations. What would be some high-risk occupations in the rural community?
Migrant workers,
Okay.
coal mine workers.
Yep. What
Farmers.
about farmers? Yep. Okay.
Would Pensacola be considered a rural area?
Pardon me?
Would Pensacola be considered a rural
Pensacola is pretty, no, Pensacola would be a big city. We're talking, pardon me?
It is?
I wouldn't, Pensacola would not be a rural.
Okay.
No.
Noted.
I feel like we just have like a bigger older population, and I don't know. I get where you're coming from, Jasmine.
Maybe an older
It sounds like
retired
it.
population.
See, I live in a town of 5,000 people.
Yeah.
And there's like maybe 8 to 10 in the whole county.
Right. And
waiting class was like 20, 24 people, something like that. And we don't even have, we have like one gas station. We don't even have a red light.
Right.
Exactly. That's rural. What Brianna's talking about is rural.
Okay.
I have a lake house up in Wisconsin, way northern Wisconsin. And in the town I live in, there's 1,600 people. It has a teeny, yeah, like Brianna said. We don't have a light. We don't have a stoplight. Yeah.
Wow.
So, I mean, that's rural.
Okay. I see. I always had a hard time with that meaning or with that.
One of the important things about rural communities is they are much less likely to prioritize preventative health. Okay. And with the kids. Okay. They're more likely to smoke, have higher risks of alcohol and drug use, obesity. They're much less likely to engage in screenings, wellness visits. Okay. And so one of the major health issues in the rural communities is chronic disease. By the time we see these rural community clients, they are more likely in an advanced stage, whether it be diabetes, hypertension, heart disease. Okay. So the research says that nearly 50% of rural adults have been diagnosed with at least one chronic condition versus 25% in a non-rural. Okay. Why are they less likely? Well, obviously they're in poorer health, but why are they less likely to seek medical care? Why do you think?
Lack of knowledge, lack of insurance, lack of understanding their symptoms.
Transportation.
Lack of doctors in the area.
Yep.
Some may be scared to be deported if they're illegal.
Perfect. Absolutely. Those are all great answers. What about language barriers? What about cultural barriers? Okay. So, and think about the jobs in the rural communities. They're typically not high-paying jobs, nor do they come with, let's say, health insurance, dental insurance, retirement benefits, vacation days.
Or normal schedules.
Yeah, normal schedules. So maybe if somebody needs to drive, they're reluctant to drive distances and take a whole day off from work because they're not going to get paid. Right? right? So when they get sick, they have more difficulty maintaining their own independence because of maybe the distance they might have to travel. I mean, in rural communities, you may have a family physician. That's it. There's no high risk OB, there's no cardiac, there's no orthopedics, right? You're going to have to travel to the next center. Okay. And lack of transportation, that's been brought up a couple of times, and lack of services, very minimal services. We also know that rural populations have higher infant morbidity and mortality rates, especially the ones with poor OB coverage. And they, as I said, they generally lack a pediatrician. All right. So, you know, if you get a family practice doctor that has a specialty in pediatrics, then that's good. But, you know, if you don't, you know, you're have a general practitioner. We know that rural clients also have a higher persistent rate of depression. Okay. It's really endemic. What does endemic mean? It's endemic in the rural populations. Do you remember what endemic means?
It's a problem specific to their area.
Well, and it's also not going away. It's endemic. Okay. They're at risk for high levels of stress, from economic to social, financial risk factors. So the four areas for at risk: forestry, mining, marine related fields, and agriculture. Right? Why do these industries have such a high risk? Well, a couple of reasons: machinery, maybe accidents with the machines, trauma, cancer, allergies, respiratory conditions, chronic illnesses, maybe birth defects, developmental delays with the kids, right? Due to maybe exposure to toxins, exposure to pesticides, herbicides. Okay. One of the greatest risks to the farm worker is pesticide exposure. Okay. That's the greatest risk. They're also very at risk for heat and sun exposure. We talked about using hazardous tools, machinery, communicable infectious diseases, musculoskeletal injuries, maybe lifting, heavy lifting, respiratory, skin, eye injuries. We talked about depression, right? And then the kids living on the farms have very similar health risks. Right? Everybody working on the farm has high risks of pesticide exposure. And I want you to have a look at this, okay? You need to know what, because you're going to be asked about pesticide exposure and the high risk for farmers. Please, let's be familiar with the acute and chronic symptoms of pesticide exposure. Okay, here's your acute pesticide exposure. Remember, this is in your book. This is in your readings. Memory loss, difficulty concentrating, mood changes, abdominal pain, nausea, vomiting, diarrhea, skin rashes, eye irritation, throat irritation, maybe a headache, confusion, and twitching muscles. Some chronic results of ongoing long-term pesticide exposure: birth defects, cancer, blood disorders, neural problems, reproductive issues, maybe Parkinson's or Parkinson's-like symptoms, infertility, sterility. Okay, so please have an understanding of pesticide exposure. And there's lots of exposures, but pesticide is the biggest in the rural migrant community. So that's why I want you to understand the difference between an acute exposure and a chronic exposure. There are a few differences with there's a lot of similarities between rural population and migrant farm workers, but there's also some differences. What do you think about when you think about migrant workers?
Long hours.
Long hours. Yep. What else?
Seasonal.
Seasonal, excellent. What else? Maybe traveling with families, moving around a lot.
Lack of healthcare.
Lack of healthcare. Again, language barrier, cultural barriers. Right? We know that they come to the US, mostly from Mexico, during seasons and then go home. They're moving around a lot. Because they're moving around a lot, they typically don't know what services are available for them. There may be language barriers, which makes accessing healthcare even harder. And they typically don't have private vehicles, so transportation is an issue. Female migrant workers have a much higher risk of sexual harassment and abuse. Right? And we talked same kind of with the kids, dangers to children working on the farm, sun exposure, pesticide exposure. And we know that our food supply in the United States would likely collapse without the work being done by migrant farm workers, right? They kind of remain the unseen part of our society. And it's estimated that 2 to 3 million of these workers work in our farms seasonally. Again, their types of jobs don't come with days off, vacation days, retirement benefits, healthcare benefits. Okay, one of the big issues with migrants is the accommodations. Okay, when they arrive at the farm to work, they may find that the housing is pretty crappy, pretty substandard, maybe lack of sanitation, mold, lead, broken appliances, and they're living in very, very crowded conditions. Some live in cars, tents, right? When housing is available, it tends to be overcrowded. What happens in overcrowded situations like that with unsanitary conditions? There's 3 big potential problems: TB, GI, and hepatitis. Okay. We know that migrants are also at high risk for diabetes, poor dental health, obesity, and depression. And then kids, when they travel as a family and the kids are working on the farms, the kids are at risk for malnutrition, infectious diseases, dental issues, maybe inadequate immunization status. We talked about pesticide exposure, injuries. Obviously, there's a disruption in their school, their academics, and there's a disruption in their social lives due to the constant mobility. I'd like for you to know about the Migrant Health Act. Okay, Migrant Health Act. It does provide primary and supplemental health services for migrant workers, including outreach clinics. These are federally funded clinics. Has anybody ever heard of the Migrant Health Act? Okay, they're federally funded clinics. And while they're working in the US, they say upwards of 3 million migrant workers access these clinics. Okay. So, questions about migrant and rural health. Let's move into poverty and homelessness. Okay. This is chapter 25. Okay. So, what do we know about poverty? Okay. Okay, so before COVID, percentage of Americans living in poverty was the lowest it's been since 1959 at 10.5%. After COVID, it climbed up to 17.3%, so approximately 48 million Americans were living in poverty. And even worse, the child poverty rate post-COVID was up to 21.4%, so about 5 million kids. And I saw this firsthand in my school nurse job because I worked in the schools before, during, and after COVID. And I can't tell you the number of families that were not in poverty that were below the poverty line when COVID happened was significant. significant. Okay. Lots of parents had to quit their jobs or lost their jobs, or, I mean, you all know what happened, right? It was a disaster economically and financially for many, many, many families. Okay. And maybe you yourselves or your families were affected. Okay. So the poverty is defined by federal government guidelines. We always hear at the poverty line, above the poverty line, below the poverty line, right? So all I really want you to know is that it is determined by federal government and various state governments. All right. So what's a definition of poverty? Poverty, poor, right? It essentially means having insufficient resources to meet the family needs. Okay, what are the family basic needs? Food, shelter, transportation, and healthcare. Right? What contributes to poverty? Unemployment, loss of retirement benefits when maybe a company files for bankruptcy, increase in female-headed households. That contributes to poverty. Inadequate education, job training, weak enforcement of child support statutes, maybe outsourcing of American jobs, increasing the number of kids born to single women. So all those are factors, okay? And then poverty leads to chronic stress, right? Living in poverty leads to chronic stress, mental health issues, high rates of chronic illnesses, higher infant morbidity and mortality, shorter life expectancy, more complex health problems. Okay. Also, some of the effects of poverty: inability to pay for health care, lack of insurance, living in areas where quality health care is available. Lower paying jobs often do not provide health insurance. We talked about that. Women of childbearing age living in poverty suffer greatly with diabetes, hypertension, obesity, asthma, HIV, AIDS, STDs, which can all lead to pregnancy complications. And then children. This is real important to know. Young children are the highest risk for the effects of poverty. Okay, so if you get asked a question, who is at the highest risk for poverty, and you get a 14-year-old, a 26-year-old, a 36-year-old, whatever, 76-year-old, young children, kids below 18 are considered young children. They are the highest risk for the effects of poverty. Okay, nutrition issues, poor brain development, exposure to toxins, trauma, abuse, maybe lower quality care at home. They may have nutritional deficiencies, growth and development issues, academic issues at school, right? More infections, maybe ear infections, strep, right? And then they're usually in a poverty cycle themselves, right? Due to the decreased opportunities. Okay. And then poor teens, that's the young children. How about teens? Poor teens are more likely to have below average academic skills, 3 times more likely to drop out of school. Higher rates of teen pregnancy, more likely to suffer complications with pregnancy. Okay, from whatever, lack of prenatal care, low birth weight, premature babies with potential birth defects. Okay, so poverty is, and if you're working in community nursing, you're going to be working with lots of clients who live in poverty, whether they're individuals, families, certain groups in the community, okay, such as homelessness, which is our next topic. What do you think about when you're driving down the street and you see a homeless encampment? What do you guys think about?
that I wish I can help them.
What about the rest of you? What do you think about?
No access to running water and possibility for, like disease and things that could happen.
Mm-hmm.
Yeah, I feel like a lot of people, homeless people here, they have like staph infection or that thing on their legs where like their skin kind of rots.
Mm-hmm. Mm-hmm.
Like just not
Mental,
no self-care.
mental illness.
Mm-hmm. Yeah.
Harm.
Yeah. Go ahead, Leslie. Go ahead.
I just said harm.
Yeah. I mean, when I drive by a homeless encampment or see homeless people, I wonder, how did they get there? What happened? I don't really know their story. I'm sure they don't want to be homeless. And especially when you see families on the street or street corner, right, asking for money or food. It breaks my heart. I always wonder if I could just stop and ask them, how'd they get there?
We took care of a homeless patient last term in Med-Surg, and he was stabbed like several times by another homeless person.
Yeah. Well, what might lead to homelessness? Let's talk about that. Many things. I mean, for the most part, people don't want to be homeless. Okay, there's been an event or an injury or a condition or a disability or some kind of financial hardship, and people don't want to be homeless. Okay, maybe they're unemployed or they got laid off, right? They don't have a regular income. They can't afford a house. They can't afford rent. They've lost access to their health care. A lot of homeless have chronic disabilities. Like Eduardo said, mental illness. Okay, mental illness, substance abuse, drug abuse, alcohol abuse, right? They typically have very little social support, family support, resources. Domestic violence, very prevalent within the homeless population. Okay. And believe it or not, homelessness doesn't necessarily, it's not necessarily confined to just people living on the street. And I learned this quickly in the school setting. If a family is even staying with friends or relatives, meaning it's a temporary housing situation, that's considered homeless. Okay, obviously, if they're living in their car, they're living on the street, that's pretty obvious. Okay, but those staying with friends or relatives, staying in temporary shelters, staying in institutions temporarily with nowhere to be discharged to, that's considered homelessness. Okay. Homeless people, what are they exposed to? What are they at risk for? They're exposed to the elements, heat, cold, crowded, unsanitary living conditions, malnutrition, lack of sleep, chronic stress, substance abuse. They're more likely to abuse substances and have serious mental illnesses. TB is very prevalent. Okay, skin infestations, chronic illnesses, and there are also a lot of crime and violence within the homeless population. Trauma is a major cause of death and disability within the homeless population. Gunshot wounds, stab wounds, head trauma, suicide attempts. And how about this? The average life expectancy of a homeless individual is 44, as opposed to 78. Isn't that just incredible? So as nurses, what's our job? What's our role with the homeless population? It's vital that we respect the individuality of every person. right? There are many, many factors that contribute to homelessness. And many of us are only 1 to 2 paychecks away from being not able to maintain our own housing. Okay, it's really easy to judge and stereotype, but most often, we'll be wrong, right? We'll be wrong in that process if we stereotype and judge, and we may destroy any chance of any kind of therapeutic, trusting relationship with the vulnerable individual or family. We can't make assumptions. That's why I say at the beginning, let them tell their story. Who they are, how did they get there? What are their goals? Where do they want to go? What resources can we get for them? Okay, so it's hard. It's really hard. And especially with this vulnerable population, the homeless, it's hard to establish a trusting relationship. They don't trust many people, right? It's up to us as nurses to try and use our therapeutic communication skills to try and build trust so that they will open up and let us know or talk about what resources they may need. Do they need a physician's visit? They have a history of hypertension. They haven't taken meds in 6 months. Do they need to see a cardiac doctor? They need food resources, food banks, shelters. Okay. Okay, so the other 2 parts I wanted to cover are here. And that is teen pregnancy. Oops, I need to share my screen. Sorry about that. Okay, teen pregnancy. Oops. We know that teens in the US are twice as likely as Canadian women to give birth and 10 times more likely than teens in Switzerland. We know that racial and ethnic minority groups have higher rates. Why is that? Because this group, racial and ethnic minorities, have higher rates of poverty, lack of educational opportunities, and higher rates of abuse and violence. Oops. Excuse me. What are some factors that contribute to teen pregnancy? Low income, lack of education, lack of social support networks, living environment exposures, maybe abuse, trauma, neglect, sexual victimization. And then remember about teens, adolescents are typically more present oriented, so they don't really think about the future when making decisions, right? Teens also, who knows a teen that thinks they're invincible? Yeah, which leads to risky behavior. Adolescents are much less likely to use birth control. And they're very limited in their knowledge of how to access reproductive services. And they also have very high risks of substance abuse. Teens who get pregnant get caught up in the cycle of poverty and school failure and are more likely to become homeless. Right? They're also much more likely to experience violence during their pregnancies. What do we do as nurses? Well, how do we counsel nurse counseling a pregnant adolescent? First, we need to identify immediate concerns and counsel accordingly. Does she want an abortion? Does she want an adoption? Is she going to keep the baby? Is she going to go back to school? Does she have any family support? What are her most pressing needs? That's what we have to establish first. Nutrition, we need to make sure we establish what she needs nutritionally. Is she going to go back to school? One of the most important things for teens, a teen pregnant client, is to keep them in school. Okay, we know that they're very high dropout rate, but we also know that education is the best the more education you can get, the better decision making you will have, right? Do we agree with that? And so to keep them in school while they're pregnant and after they're pregnant, in our district, it's a huge district I worked in. We had a school that part of the school was for pregnant high schoolers and some middle schoolers, where there was a nurse on site and they focused on these pregnant young moms. Okay. And we truly, truly encourage them to stay at school, because the more education they can get, the better decision making for both them and the baby. Therefore, hopefully, the risks will be less. Okay. If you're working in the community and you're doing home health visits with new teen moms, we know that one of the biggest things they struggle with is bonding. Okay. Do they make eye contact with the baby? Do they know how to meet the baby's needs when the baby's crying? Is the baby hungry? Does the baby need a diaper change? Do they smile at the baby? Do they sing? Do they engage? Really important stuff. And out in the community, that's a big job. That's a big role in the community nurses, is new family, especially teen visits. And then the other big vulnerable population is mental illness. Huge. Mental disorders occur all across the lifespan. Post-COVID, we were seeing mental instability, mental issues with preschoolers. You know, from being out of school, from isolation, no social contact. Really, it was real hard to get a 3 and 4-year-old to learn online. Right? Major depression is is the major leading cause of disability in the U.S. We know that Alzheimer's has been rising consistently. Over 6 million Americans. Right? Research suggests that about 10 million adults in the U.S. have serious mental illness, leading to significant disruption in daily living. Okay. So mental illness also is kind of a comorbidity with physical disabilities. Okay. So tell me about your experiences in your employment areas with mental health issues. You don't necessarily have to work in a mental health institution to be exposed to mental illness. It's everywhere, is it not? What are you guys seeing out in the communities? Are you seeing an increase in mental illnesses, increase with struggling kids, teens, adolescents, elderly? What are you guys seeing?
Kids are definitely becoming more aware. So my aunt, she is a travel nurse in Alaska, and she does psych for children. And she's saying that now kids as young as 7 and 8 have their whole suicides planned out, and they know how they're going to go about it and stuff like that. So I feel like kids now are more depressed. Kids now, I read recently that they're starting to abuse their Adderall and Ritalin at younger ages now. I think they're scared. They're definitely scared, but a lot of things that they go through now, we didn't have to go through when we were their age. So I just feel like they're kind of over it. The depression rate in kids is like going up dramatically.
And I feel like COVID played a huge role in that too.
COVID, the school shootings, like a lot of that. Kids are terrified now. It's really sad.
I feel like every med pass I do, somebody's taking an antidepressant.
Yeah, I feel like something super weird too is like my little girl is 4 and I'm already seeing like body image issues in my 4-year-old. That should not even be crossing her mind. That should not even be, I mean, I feel like there's just so much pressure on these babies.
Mm-hmm. And that's what they are. Babies. Wow.
Same thing for our geriatric population. I work in geriatrics, and we've seen a huge rise in depression and anxieties and even suicide. We've had 2 suicides in a facility that we go to in the last year, just because of, I think, post-COVID. COVID really was hard on our geriatric community because the small people they did rely on were, staying to themselves and trying not to expose their loved ones to anything, and being alone for extended periods just was not healthy for them.
I feel like even without pressure on kids and moms, like as far as like what she was saying about her 4-year-old, and like nobody really talks about postpartum depression. You're expected to bond with your baby. You're expected to be there, but nobody really talks about it. If you have depression, don't get help for it, because then you're a bad mom because you don't like your baby or you feel that way about your life.
And our geriatric population is very sensitive to not wanting to put strain on their kids or their grandkids to help take care of them because of how hard it is to make it nowadays. I mean, you almost can't survive with a single income family anymore. And a lot of elderly people don't want to put burden on their loved ones, for anything anymore. So they just don't ask, or they deal with whatever conditions they have until it's too late.
So true. So true. Anybody else want to add to this discussion? Mental illness is a phenomenally large problem and getting larger. And the resources are pretty limited. And it's, in my humble opinion, it's pretty scary.
I work at a local hospital, and I'm a nurse extern, and I've seen way more people, like younger people, come in with like suicide stuff, and I have to sit for them because it's a big rec, so you have to have a sitter. And I've seen a lot more younger population than older recently, so it's kind of sad.
Very sad. And the rate of suicide has skyrocketed with
But I feel
kids.
like nobody takes people seriously. Like they have to get to that point for somebody to take them serious.
Mm-hmm. Yeah.
I recently had a baby in March, and I went into, after the 3rd week and I was still hysterically crying, I went into my OB and expressed all these feelings, and here's an antidepressant, here's some Buspar. It turns out I had bipolar disorder, and they were not treating me because my moods were unstable. Mm-hmm. And I had to go as far as having all of those feelings for them to actually take me seriously and to take me off antidepressant and put me on something for mood.
It has come to the point where a lot of people do just throw a pill at you, or they don't listen completely to where it needs to be contributed into your care.
Mm-hmm. I also believe that there's a lack of training for certain individuals to understand what they're looking for. My son has ADHD with depression and anxiety, ODD. What happens a lot of the times, they take his depression for his oppositional defiance disorder. And so instead of actually listening to him, that he just feels like crying and can't get it out, they'll put him in BIC, which is indoor CSI type of situation, where they won't, acknowledge him. But there's also the therapist He has had a switch of therapists within the last 3 months. He's had like 3 different ones. And now at this time, they can't find anyone that has availability to be able to see him. So how does he handle his emotions, you know, when he doesn't know how to express them? So his lack of resources as well.
Right. Sorry, this printer's going off next to me. Sorry about that. Can you hear it? Sorry. I didn't hit the printer. Think about the rural population with only having a GP, right? Think rural population only having a GP, and we know that mental health issues are huge in rural populations, and there's no support. You have to travel a long way to get support. Long way.
Yeah, you gotta have a psychiatric to actually prescribe you medicine. So you have to have a referral and all kinds of stuff.
Yeah, absolutely.
A large burden to put on somebody to be all of those people in one specific area.
Right. Exactly.
And too, when you're raised in a really rural area, it's like there's so much taboo around. It's like so taboo mental health is, and it's like when you're raised in the South, it's like you just gotta suck it up and go on. Right. You're told than that. It's just like they don't believe mental health is real.
And there's such a stigma, right?
Yeah.
And the stigma is getting bigger and bigger, right? Yeah. I mean, it's crazy. The other thing I wanted to talk about was, I don't know how to turn this printer. Alcohol, ATOD stands for alcohol, tobacco, and other drugs. Okay, this is, let's see, this would be chapter 26. Okay. So this just kind of goes along with what we've been talking about. All right, we know that alcohol, tobacco are major drugs of abuse, right? When we're talking about substance abuse, drug addiction, chemical dependency, right? We know that substance abuse contributes to teen pregnancy, HIV, STDs, domestic violence, child abuse, motor vehicle crashes, fights, crime, homicide, suicide, right? We know that tobacco contributes to cancer, heart disease, lung disease, bronchitis, chronic airway obstruction, maybe premature births, low birth weight. Okay. What do we know about it? What are some contributing factors? Okay. Maybe mental health, the state of your current mental health. Right? Family history. Maybe predisposition, genetics. Right? Maybe their chemical makeup. Maybe there's usually underlying comorbidities, right? Mood disorders. People may say, and then people try and self-medicate, right? Social conditions. What are some social conditions that influence alcohol, tobacco, and other drugs? Peer pressure, maybe in the kids, peer pressure.
Peer pressure, and then just curiosity out of all of that.
Curiosity. Well. Yep. What else?
Social media.
Yeah, big one. Social media. Yeah. Maybe television.
It could also be what they see at home.
Yeah,
absolutely, family. Michelle. What they see at home. Absolutely.
Advertisements in general make things more kid friendly.
Yep. Absolutely.
Colorful pictures.
Yep. Some terms and definitions to be familiar with. What's the difference between substance abuse, drug dependence, drug addiction, alcoholism. There is a difference. Okay, so have a look at what the definitions of those are. You're going to get asked about on the next exam. Okay, and then have an idea of the big what am I trying to say? The different kinds of drugs, right? So you have your psychoactive drugs, right? Which are your depressants, your stimulants, your energy drinks. Right. So I just want you to understand the categories. So be able to define what a psychoactive drug is versus what's the other one? Sorry. Oh, and depressants. Okay, so psychoactive and depressants. Okay, be able to identify which category alcohol goes in, cocaine, amphetamines. Okay, and you can read about this in this chapter. There's going to be a little bit covered on the next exam. Not a whole lot from this chapter. I want to get into these other chapters. I want to talk about. Okay, so that's it for the kind of the hard topics. I want to talk about faith community nursing. When you guys think about faith community nursing, what do you think about? What's faith community nursing?
That'd be like maybe like cultural, somebody who helps.
I'm gonna read from these notes. Hang on. Faith community nurse. Okay. Faith, you know where I'm going to read from real quick is I'm going to go back. There was a nice description in your week 4 announcement talking about the differences. Okay. Whoops. So, well, I need to move you guys over here. Here you are. Did you guys read through this? So, this particular week covers different roles of community nurses. Okay, this week we cover faith community nurses, home health nurses, hospice nurses, palliative nurses. Okay, so as we talked about in week 1, there's lots of different roles for a community nurse. In this particular week, we look at a variety of roles for public health nurses and the importance of understanding the law and our scope of practice. So for faith, home health, and hospice nursing. All right, so from our readings, if you prepare for class, faith nursing is the intentional integration, all right, of the practice of nursing with the beliefs of a religious community, irregardless of what that is. Whatever religion you practice, there's lots of them, right? So typically a faith nurse is an RN specialist with very strong ER, med-surg, public health experience who encourages physical and spiritual health and wholeness, right? By developing and leading programs within faith communities. Okay. And then we also want to talk about the hospice and home health nursing, right? They do share some similarities, right? But they also identify how to approach care, addressing distinct patients with unique needs and goals. For example, well, you guys tell me, what's the difference between a hospice and a home health nurse? Who is a hospice nurse caring for?
People at the end of their life.
Okay.
Also providing
comfort care.
Comfort to, it's not just the patients, but also possibly families.
Yeah. Yep. Hospice nurse provides comfort care to a patient with advanced illness when curative medical treatments are no longer effective or preferred. On the other hand, home health is curative. So that's the difference. One of the differences. Hospice nurse is working with clients with a non-curative issue, right? Home health is working with curative. Home health is working with clients that potentially have a curative outcome, right? They're intended to help patients recover from illness or injury, right? You're trying to help them move towards independence or functionality, regain what they had. Make sense? Let me go to my notes here. So, faith community nursing. All right. Just when I think of faith nursing, I think of like a parish nurse. Okay. Most of your congregations, wherever, if you have a religion and whether you practice in a church, a mosque, a temple, right? Most of your congregations, or at least the larger ones, will have some kind of a faith-based nurse. I have 2 friends who do it in Colorado. They've been doing it for years at the same congregation. And their roles are exactly what I teach in this section. All right, it's much more community oriented than community based. And you remember, community oriented is you're looking at the community as a whole, trying to figure out what the needs are, the desires are, the goals are, the issues, right? And the big, not difference, but the big addition to faith-based nursing, it incorporates spirituality into your nursing practice. Okay. Faith-based nursing is built upon health education, health promotion, and coordination of community resources while incorporating spiritual health and religious practices. Their main approach is holistic, which incorporates body, mind, and spirit into their healthcare approach. Okay. So for a lot of people, religious and spiritual beliefs have a significant impact with regards to how they see and cope and deal with their health, right? Whether it be acute or chronic illnesses, birth of a child, death of a family member. There are populations that have very strongly held religious and spiritual beliefs, right? And these beliefs and values and practices are incorporated into their daily routines, right? Well, the difference, I'd like you to know the difference between religiosity and spirituality. Does anybody know the difference from their prep work? Okay, it's pretty simple. Religion focuses on specific traditions. Okay, so for example, I'm Catholic. Okay, so my religion is Catholic. Somebody else's maybe Episcopalian, somebody else may be Lutheran. So religion reflects the traditions or the denominations that I practice or you practice. Okay, it's one religion. Okay, whatever you do. Where spirituality is your view of your higher power. Okay, so here it says spirituality is the individual's attitudes related to a higher power and to the non-material nature of life. Okay, many people don't have a particular religious they practice, but they do have spiritual beliefs. Okay. And like every part of nursing, I know this is in the faith section, but in every nursing practice, nurses should approach each client with an open mind and ask open-ended questions and be flexible, right? If spirituality is vital to your client, it should be incorporated into their care, right? Request a visit from their preferred chaplain or spiritual advisor if they ask to pray with you. If they ask you to pray with them, allow them regardless of your own beliefs. Listen for clues that they need a spiritual coach. You know, if somebody says, why is God punishing me? I'm scared of what comes next. What if I've not been forgiven? You know, when you hear these things, you have to try and ask, repeat back, or repeat open-ended questions, right? Tell me more about it. Maybe you can help them determine if they maybe need a spiritual advisor or chaplain or religious leader to speak with. Okay? Does that make sense? And then your home health nurse. Whoops. What about your home health nurse? I'm going to, hang on one second. I know it. Hospice. Okay, let's talk about home health and hospice for a minute. I'm just going to read from my notes here. Okay. One of the, oh, actually, I do need you to know this. There's two definitions in faith-based practice, okay, or two models. One is the congregation-based model, and the other is the institutional-based model. Have you guys read that in your preparation? Do you know the difference? Can anybody tell me the difference? In a congregational model, the faith-based nurse is just working specifically within the congregation. Okay. Whether it's new parent home visits, whether it's support groups, grief support groups, taking communion to people in the community, teaching, having new parenting classes or pregnancy classes. Okay, they're just dealing with the community, their congregation. Where institutional-based model means that they are partnering or coordinating with outside agencies to also provide services within the community, such as transportation or Meals on Wheels, or you know, getting clients to their physician visits. Okay, so they're partnering with baby clinics or physical therapy, occupational therapy. Okay, they're partnering with outside people to bring care in. Does that make sense? So congregation, they're working specifically within the congregation. Institutional, they've now partnered up with a community to provide additional services for their clients. Okay. Answer me this. How do faith community nurses act as an advocate for their patients, for their clients? What would you think from a faith base?
Getting them their chaplain.
Getting them what?
Their preferred chaplain.
Mm-hmm. How else? What is nursing advocacy?
Speaking for your patient.
So what might
your patient?
Pardon me?
Fighting for your patient.
Yeah. So within a faith community nursing role, what additionally might you be advocating for?
Maybe if their religion is against getting blood.
Yeah, patients' right to whatever religious practices or beliefs they hold.
Exactly. Yeah. What if you're working with a family? Let's say you're a hospice nurse. This hospice, home health, and faith community all kind of fall under the same umbrella. What if you're a hospice nurse and you're working with end of life client and you have family members that don't agree with what the plan of care is?
You need to change it.
What if the client has communicated what their wishes are and family members don't agree?
Well, you have to advocate for your patient.
Exactly. I'm just reading through the sections on your next study guide that you're going to get. Hospice nursing. We already talked about it. End of life care. What are the primary functions of hospice nursing? We did review it, but let's talk about it again.
Comfortability.
Comfort care. Dignity. And hospice, somebody already mentioned, we're just not taking care of the client, but we're taking care of the entire family.
Long term.
Right? What?
Could potentially be long term or weeks.
Yep. Home health nurses. We say in public health that the home health nurse and the visit the home health nurse does is one of the most important visits that take place. Right? When you're a home health nurse and you're going into homes, you have the ability to assess everything. Even though you may just be going in for a wound change or a dressing change or a IV med or checking in on their medications. A home health nurse really has the ability to expand those assessment skills out to do safety assessments, environmental assessments, relationship assessments, communication assessments, cleanliness assessments, right? Does anybody visit patients' home? Does anybody work in home health? Yeah. What do you guys?
A lot of the.
What do you do?
What? A lot of the times we could be the only ones that are there or that have seen this patient in a while. So like we're the only ones that they talk to or communicate with. So that being said, we get to learn a lot more about them and how they do live their daily life and any concerns that we might have to give to a nurse at the moment. Since we're not a nurse yet, we were like the STNA of the home health area at the moment.
I feel like we catch a lot more things in a hospital or going to a doctor's office ever would. Because we see the conditions that they're in. We see that they're not doing their pills correctly. We see, their cleanliness, if they're eating food or not, if they have food in their house. And that's all stuff that you don't get that picture when you go to a hospital with a patient or to the doctor's office. You just assume that what you prescribe is being done, by the patient correctly. And a lot of times it's not.
Yep. Jonathan summed it up beautifully, is you are in a better position to do a full assessment than if they get admitted to the hospital or show up at your ER, right? You are actually in their home environment, right? Yeah. You're able to maybe potentially see signs of abuse, if that's happening, whether it's child abuse, elder abuse, domestic abuse.
I feel like there's a question about this on the exam.
About what?
About like home health.
Oh yeah.
I forgot what the question was, but it was like you go to a home health visit and you observe like the family. And the dad is talking to the daughter more than everyone else or something like that.
The one thing you need to review is safety. There is in your, I believe it's chapter 30, there's a safety checklist. Know that. Have a look at that. Because in home health, we also have to prioritize our safety. We have no idea the environment we're walking into. We may not know the community well. We may not know the clients well. I'm sorry. 1 second.
Is that the?
Sorry about that.
Is that the checkbox that's like keep your phone charged?
Yes, keep your phone
okay.
charged, leave a schedule at your office, so that if somebody has to reach you. One of the important things is, a lot of people don't know this, but it's suggested that you position yourself between the client and the door. Why is that?
More safety
you
because
can
you
get
don't
out.
know if they
Right, right. And then another thing, I think you'll get asked about this, but guns, firearms in the home. What is the first question you ask when you come into a home?
Where do you keep your gun?
Before that.
Or not the first question.
Are there guns in the house?
Are there guns in the house? The answer is no. Fine. If the answer is yes, what's your next question? What's your next statement? This is really important.
How do you keep them safe from small kids?
Okay.
Are they loaded?
Okay, so Emma, you're mostly correct. But the next question is, show me where they're stored. Right? Because what if they say, what is Emma, what did you say? You said, do you keep them safe from your kids? Well, what they say yes, okay. What if they don't?
I'm saying, how do you keep them safe from kids? Like,
right.
Where do you store them? How do you,
there.
like, what safety measures do you take?
So, do you have firearms in the house? No. Yes. Please show me where they're stored. And what are you looking for when they're stored? What are the two things?
Behind a lock.
And
accessibility
safety features
and whether
unloaded.
they're loaded.
Unloaded. And does the ammunition have to be in a separate place? Yes. Those are your three, sorry, not two, three. Are the firearms not loaded? Is the ammunition in a separate place? And are they locked? And one of my first terms at Fortis, I had a woman, a student. She was a firearms instructor. Boy, did she grill me on that. She said, I would never show you where my fire, you know, I get all that. But for purposes of this class and a home health visit, you have to ensure your personal safety. Right? Does that make sense?
These are the things that need to be disclosed first and foremost.
Yeah, exactly. Exactly. So anyway, so let's see. I think that's what I wanted to cover today. So we covered 2 weeks. I know it was kind of long, but what do you think? Too much information, good information? Do you have a better understanding of the different roles in the community? And then rural and migrants, that's covered heavily on the next exam. So I think you should be getting, oh, go ahead.
Is there a way we can access what you were like looking at, like you were going through?
Those are kind of my instructor notes. They'll be you if you watch the recording, you can see them.
Yeah, the book is. Yeah. I don't like the book.
I know. I kind of develop my notes from the book. So, hopefully you'll be getting your exam 2 study guide by the end of the week. I hope, because next exam is for you guys is week 6, and it will cover weeks 3, 4, and 5. Okay, so we've just done 3 and 4. So after next week, I mean, believe it or not, next week's already review week for exam 2. So take a look at the schedule. Take a look at the schedule.
What chapters?
Go ahead, Jasmine.
I was going to ask what chapters are covered in this exam.
Well, we go back and look at your syllabus, weeks 3, 4, and 5. I can tell you this week 3 is 24, 25, 26. Week 4 is 4, 29, and 30. And I don't have week 5 memorized. You could go back to your syllabus or your module for week 5 and see what chapters are covered. Okay. But remember, you don't need to read every chapter from start to finish, right? You have to look at your objectives hang on. You have to look at your objectives and try and answer those, right? And 1 second. So look at your objectives in all these chapters, right? That's the part of the book that you want to read, right? You want to be able to answer your objectives, right? So don't read every one from start to finish. Okay. So, oops, sorry. Yeah, and you should get your study guide here pretty soon. Okay. So that's all I have. I hope you felt like you learned a lot today. We covered 6 different chapters, 6 different chapters. Okay. So now you have your week 3 and 4 info. So when you get the study guide, technically 2/3 of it should have already been covered for you. Okay. And then next week we'll do the other third. All right. Then you know where to find me. Again, if you'd like to review your exam 1, reach out, please. Give me a couple of days and times, and I'll do my best to be flexible. Since we've started these at-risk meetings, I've got like 8 a week. No, yeah, about 8 a week, every week. So, and then teaching the 3 classes. So I try and do quick half-hour tutoring sessions in between all these meetings. So just give me some days and times that work, and I'll make it work for you. I can do the weekends, whatever you need. Okay. Good to see everybody today. Have a good rest of your week and reach out if you need anything. Okay.
All right. Thank you.
All right. Bye, everybody. Have a good rest of the week. Okay.
I have a quick question for you.